The war in Vietnam is different. The enemy is active over most of the countryside, and rarely is there a conventional battle line. Every man must take with him into combat the certain knowledge that he has the inherent right always to defend himself against hostile action.
But I remember laying there and kind of looking down, and you know, I just had a lot of blood on me, and I could taste blood in my mouth. You know, that was a little scary. But I wasn't hurting. But within a matter of just a few minutes, somebody kind of slid up beside me, and it was one of the medics. I had a pretty nasty wound in my shoulder and my arm, top part of my arm up here, and had a bunch of little, almost like bird shot or something, you know, small shrapnel in my side, in my leg. My arm was the main thing. It looked bad, and it scared me pretty bad, I guess. But you know, he kept telling me you're gonna be okay, you're gonna be okay, you're gonna be okay. They picked me up, and you know, I went out with several others. But that was Purple Heart and a Bronze Star all in one morning.
Army Specialist Manley Barton was one of thousands wounded during the Vietnam War. Hundreds of Medical Corps members served with combat troops, treating their wounds. I'm Dr. Rick deShazo. We'll hear more from Manley Barton and other Vietnam vets, but first, Dr. James Hughes joins me to share his experiences as a field surgeon during the war.
Southern Remedy is underwritten by a grant from the University of Mississippi Medical Center and viewers like you. Thank you.
The Vietnam conflict in which we served established lifelong friendships and collegiality throughout the years. Much communication, much involvement in the family dynamics of each of those that we served with. So it's a real privilege, and it's a lasting privilege.
You were deployed directly from your surgical training to a combat zone.
Correct. I had 2 years of general surgery, and this went from Fort Rucker, Alabama, where I was stationed for the first year. Then when the 173rd was deployed in May of 1965 to Vietnam, I was embedded with them. So I went to Vietnam in that capacity as a fellow participant in that 173rd Airborne Brigade.
We have our casualties, but our fatalities from combat-inflicted wounds have been cut to less than 2% because of the speed with which a wounded man can be moved from the battle zone to skilled surgical help. Usually less than 30 minutes after being hit, a seriously wounded man is in the operating room.
You were actually in the field of battle with these airborne soldiers, is that correct?
That is correct. For the first 3 months I was in Vietnam, I served with the 173rd. When they had a mission in the jungles, we would go right behind them and embed a first aid unit, as it were, within that field of service that they were in. Then from there, they would be transferred to a MASH hospital, which in this case was 7th Surge Hospital, where then I served after 3 months in the Airborne. I went to the MASH hospital.
Now, the field hospital was actually a tent-based unit with sawhorses in which they actually brought troops on stretchers right out of the field of battle into care, right?
That is correct.
And what kind of injuries were they experiencing?
Well, these were obviously gunshot wound injuries. They could be punji stick injuries, but they dust off, we call them. The helicopters would take them from the field where we first evaluated them, then brought them to the MASH hospital where the triage area was noted. The physicians would swarm them, prioritize the treatment protocols for the injured, then taken right to the surgical suite if necessary, or transferred to the next consideration above us, which was in Saigon, which was the evac hospital.
That whole system of care evolved in the Army out of the MASH units in Korea and so forth. And as I remember, it has to do with how much time you have to take care of somebody after they've been severely injured. that dramatically affects survival. Is that correct?
That is absolutely correct, Rick, because now we use the term golden hour. If you take an injured person and get them to the proper resuscitative facility within the first hour, the chances of them remaining alive are significantly high. So that evolved. We didn't call it that in Vietnam, but it was functional in the way that the sooner the soldiers could get care, the better they would outcome would be in their total recovery.
There were also a whole separate group of medical illnesses that our troops experienced, including malaria and I'm sure that you saw a lot of foot problems that were out there in these swamps.
Because it was so moist and so hot, and the troops couldn't bathe properly, that we saw tremendous problems with feet in terms of fungus. And the other consideration, Rick, is that was the rice paddies themselves. When a soldier was wounded, if he was in the rice paddy, that water, the contaminated water, would wash into the wounds, and it was horrific in terms of the sweeping of bacteria through one's body but just by the opening there. So that's, again, on the trauma side, but on just the everyday side, you did have the problems with the skin. Malaria, we didn't see much of because we had to take the pills at all times to suppress that consideration. I would say one thing that we did see not often was a psychological difficulty among the soldiers because of whatever reason the war got to them. And so there were some psychological evaluations that had to be made, and then the soldier had to be shipped out because they could not function anymore in that environment.
You were in a combat zone. I was in Walter Reed in a referral hospital. It was many steps removed from yours. But even so, my experience as a physician coming out of training in the U.S. and being placed in a scenario where you were seeing guys who were your age and younger severely injured or ill, in my case they had illnesses, was a shock to me personally. I had never experienced this level of injury in the U.S. Were you at all shocked by this experience?
I would say it was sobering, Rick, because here we have our fellow Americans severely wounded in the prime of their life or even killed. And if you dwelt on it, it was problematic. But if you just cared in a compassionate way and considered your role to assist them, then you could function appropriately.
Well, and during this period, the whole knowledge base about combat and what it does to your psyche was just evolving. And at least from my experience with physicians, you just sort of got through the day and didn't think about what was going on, and then sort of later realized actually what had happened.
There were moments when you considered both the joys and the horrors of serving in that kind of consideration. But I found myself not allowing myself to dwell on it because you just are grateful for those that you could take care of, those that you could impact their life, that they may recover in a proper way, and forget or put into a quiet part of your being the horrors that you did witness.
This second unit, you actually had nursing care and anesthesia and colleagues to help you.
You know, had excellent surgical assistants, and they were well-trained and fully integrated into the team. So it was very much a team like we would have now, which you have scrub techs, you have nurses in the OR, the anesthesia, and all the equipment that you need for the initial resuscitation and repair.
I was really intrigued to see how commonly you were involved with Vietnamese people in combat zones, the villagers in these areas. And I don't think a lot of people realize how much medical assistance was provided to them.
Rick, it was a real privilege as a physician to serve the people for whom we were fighting for. And it was wonderful to be able to go out with the children, to see them, to take care of them. And that's called just local medical teams went out into the considerations. You know, Rick, we were also soldiers. And in that consideration, we were under the authority of the administrative officers that we served under. And many times we were deployed not only into the villages to take care of the villagers, but also it would be a cover to recon that area to see what the enemy activity was. In one instance, we were used to take a radio and hide it into this village to monitor the activities during the night, but we were used as a cover to get that radio into this area.
Some of the ones that you were able to identify were ill in the villages, you actually brought back to the surgical unit and
That's correct.
And attempted to fix the problems.
That's correct. In one instance, we went into this village and the Vietnamese army was bringing this woman out on a big oak door, and the sergeant and I picked up the litter and continued to bring her out from the war zone and eventually brought her to the hospital where she was operated on and survived.
So there were a lot of Vietnamese citizens sort of caught in the crossfire between the forces that were fighting all around them.
That is correct, and we took care of them. If they were brought to us, we took care of them.
We appreciate your service, Jim, and we appreciate your being with us today.
Well, what a privilege, and thank you. I represent all those, as you said at the outset, all those men and women in the medical corps that I was privileged to serve with.
PTSD is real. It's difficult to be in a situation where you see people being killed.
And I always remember when we came into Travis Air Force Base, there was all lined on both sides of the roads. There was people giving us the finger, and we were baby killers and everything else. But I tell you, that just done me in after you've seen what had happened to so many people. And you know, and I'd seen guys that hadn't even started to shave yet, and they got killed.
People didn't want to talk about Vietnam. They didn't want to hear that you were a veteran. They didn't want to hear your experience. So you kind of pulled it all inside and you sat on it, you know, and it made it difficult.
To see these bodies, and sometimes they'd be torn apart, you know, a leg missing and an arm and half the head torn off or something. It was a fact that you hadn't seen before. And you'd have to steel yourself against it. So what you would do, you would try to act like it was a everyday occurrence, so to speak.
The feeling that, you know, you ought to be able to handle it. You know, you ought to be able to deal with it, you know, just other people do, why can't you, you know, kind of thing.
We had 2 or 3 situations where our camp was attacked and where we killed some of the attackers. You can't be walking and say, well, because this is not something you see every day. This is not something that you can just walk away as being normal for you. And prior to being in Vietnam, the only dead person I'd seen was some, you know, relatives at a funeral, not someone who had been torn apart or who had been shot and these things. And it carried over to me to a degree. That's when I went to the mental health place after that.
I did a lot of counseling with these guys. And when I say counseling, I'm not talking about me talking. I'm talking about listening to them tell me what they took me as a comrade in arms because I was in the military. And they would tell me things that they couldn't possibly tell their wife or their parents or anybody else. To the degree that sometimes Mark and I would spend up 24 hours straight listening to these people and helping them. And it got to a point that when we had a welcome home in Fort Collins, Colorado, when it was hard. These people it was like a family. It didn't make any difference what branch of service you were in or what you did. All the special forces came together. You had to be there to see that, only because they knew that when they spoke to somebody, that person understood what they had been through.
Vietnam was all I could think about. I mean, that was all I could think about. I mean, I had left. All my friends were over there. I didn't know what was going on. I didn't know where they were. I didn't know what was happening to them. And you couldn't get news to that detail. I mean, you know. And so, and I struggled a good bit after a few days with the fact that no one here seemed to be as interested in it as I was. And so I spent several weeks kind of getting madder and madder, I guess is one way, but I was really hurt in many respects. And they wouldn't have understood it, so there was no way to explain it. No one was thinking about it like I was thinking about it, and I thought they ought to. I mean, that's been one thing that's kind of lingered with me through the years. I needed some time away to kind of readjust myself.
A lot of guys turned to drinking. A lot of guys turned to, they couldn't let it go. It was just the whole horror of it. They couldn't let it go.
Navy veteran and psychiatrist Dr. David Walker joins me to discuss health issues for Vietnam vets. He is the director at the Jackson, Mississippi VA Medical Center.
PTSD seems to be sort of an epidemic among soldiers presently in combat situations. When I was in the military before your time, that was a rare term. What's going on with this? Did we just ignore it, or what? And what is available for our Vietnam veterans at the VA here in Mississippi?
So one of the things is that if you look now, when you ask an Iraq or Afghanistan veteran if they were deployed, you're going to get numbers. So it's how many times were they deployed. So it's not uncommon for veterans to have been deployed 3, 4, 5 years in Iraq. And as one is exposed to combat repeatedly, they are at an increased risk. Now, we also know that there are treatments that have been developed that weren't in existence in the Vietnam era, and there are medicines we used during that time that we now know should not be frontline or first-line agents. So the evidence-based psychotherapies have been shown by far to be the most effective. We have both outpatient and residential treatments for PTSD, and also substance abuse, because oftentimes there's an overlay with PTSD and substance abuse. And then medicines like benzodiazepines, that class, they used to be frontline agents, of the first ones to go to. We now know the way they affect memory, that actually they should be last resort agents. And so through evidence-based practice, we've learned things we didn't know before. And then I think because of the repeated deployments and the fact that there is a push to evaluate military members before they leave active duty, and of course to evaluate them in our system for PTSD. So I think all those things probably make the picture a little different.
Well, there used to be a disconnect. When you got discharged, I remember when I got discharged, I don't remember your discharge situation, obviously, but I was given my records and told adios. The VA wasn't even mentioned as a source of health care when, after nearly 10 years of service, I was discharged. Is it better connected now than it was?
Yes. So, for instance, we send staffed. We call them, there's stand downs, where if a guard unit is demobilized, so they've come back, we actually send staff there to educate them about the VA. It's also part when folks are leaving active duty to educate them.
Specifically addressing the Vietnam veteran, do Vietnam-era veterans have a different set of medical issues than the present veterans from Iraq and Afghanistan?
Yes. What we find is that our veterans in Mississippi have more health problems. They have higher rates of cancer, of diabetes, of hypertension. And so as they age, those things worsen. We also know that when one is in their 70s, and many of our Vietnam veterans are in their 70s, their life changes. So they may not be working anymore. So those things that allow them to cope may be gone. And so you can actually see a recurrence or a worsening of post-traumatic stress disorder type symptoms. And then the medical symptoms and comorbidities that we would call them, multiple conditions, are actually significant, because we have some of the most physically ill veterans in the system.
The Mississippi medical problems that are seen among all Mississippians are an addition to whatever existing military-related problems that they have.
That's correct. And then you can add if they were exposed to Agent Orange or other things that have impacted them too.
What about mental health issues?
So depression is also significant. Depression and PTSD are commonly seen and again worsen. And then also suicide. If you look at suicide, about 20 veterans a day nationally are suiciding, and about 12 of those are not in our system. So we've even developed an algorithm where we can predict who's at most risk, and then the clinicians actually contact those veterans, because as one ages, there is a higher incidence of suicide.
I keep hearing reaching out, which is something that I didn't experience after my discharge. There is a real effort to continue to have a relationship with those veterans who want it.
Oh, yes. And I actually go into the community doing town halls, do them not only locally, but throughout the state, at least a dozen times each year, because I know that there are thousands of veterans in Mississippi that are eligible but haven't signed up. And I know that not everyone can afford to drive to Jackson. And then we also use technology to even provide treatments. We can even do some treatments, even mental health treatments, in the home.
So what VA facilities are available in the state as a whole? I know we have some on the coast. I don't know much more than that.
Okay. So the Memphis VA covers the northernmost part of the state. Jackson VA, we have 7 clinics. We have Greenville, Kosciuszko, and Columbus, Meridian, and then Hattiesburg, Macomb, and Natchez. And then the Biloxi VA has the coast. But a veteran can choose any VA they want regardless of where they live. And so we also have veterans that choose us that are living north, in the northern part of the state, or in the southern part of the state. But that's the catchment area we serve, and we have about 44,000 currently in our system. About 17,000 of those are Vietnam veterans.
What kind of problems would allow someone to opt out?
So what it is the choice program is designed to provide care if we cannot provide it timely or if we do not provide it at all. So for instance, we cover obstetrics care for female veterans, but we don't have an obstetrician. We do have a gynecologist, and we do women's health, but that we buy in the community. So that would be an example of something we don't offer, but we cover. And then the way the law works is if we can't do it within 30 days of the clinically indicated time, then the veteran can choose to go into the community. Now, the community may not be able to provide it sooner, but that would be the veteran's choice.
You actually have staffed up with all the new veterans coming in over whatever level of staffing you had for the Vietnam era veterans. Are you getting close to having enough resources to actually take care of all these people?
So we have the resources. Where we have struggled is enough primary care physicians, and we have a mixture of primary care physicians and nurse practitioners, but we're competing with the community for a small number of primary care doctors. So that's where we've really struggled. And then in certain of the subspecialty surgical areas, we have them, we don't have enough, or we might not have them, it depends. But primary care is that area where we are really using choice in ways I would prefer not to, because I would like those veterans to be in our system. But regardless, we still coordinate the care. Even if they're getting treated outside of our system, we coordinate the care.
And what does that mean?
So you could be seeing a primary care doc in or out of our system, and then you need to see a urologist. We'll get you a urologist. That likely would be in our system. And we're going to have somebody that's looking at all the care that you're receiving to make sure that it's coordinated, that nothing is dropped or missed. So if you see one specialist and they recommend something, we want to make sure you get that.
Well, we appreciate you for both of your services, both as a veteran and as a VA leader.